Dr. Norm Hoffman, welcome to Life After Impact. How are you today?
Wonderful, thanks.
Excellent. Well, our topic today is on chronic pain. This is something that, I've lived with chronic pain for I don't know how many years. At first, it was low back pain, and then it was a brachial plexus injury. Um, and I had a very interesting experience where I had low back pain for many, many years, had tried, everything under the sun for it. And once I injured my shoulder and I was in excruciating pain, I felt like I was walking around with a broken collarbone. This was on top of several concussions. My low back pain disappeared during the year and a half that I had excruciating left-sided collarbone pain. After I tried, again, so many things for that, I did platelet-rich plasma injections, and it got about 95% better. But I swear to you, the moment this pain went down by 95%, my low back pain was suddenly there again. And I was like, okay, brain, why? Why do you have to do this? I was so happy about having no low back pain. Now it's back. So talk to us about the brain and what is going on with chronic pain that makes it different from acute pain. And then eventually we're going to get into the role of when you layer a concussion or a traumatic brain injury into this mix, that just makes it that much harder to treat. So I'm going to give you the floor here.
Okay, so let's talk about the brain and pain. Brain basically kind of sees, it doesn't really know the difference between acute pain and chronic pain, but it treats them differently. Chronic pain as a whole comes in two flavors. So chronic pain can be local pain that has simply remain unresolved, such as your low back or your shoulder, right? And it just persists and persists and persists, but it stays more or less where it is. And then there's a second flavor, which is chronic widespread pain, which is I started off with a low back pain. Now my knee also hurts and my shoulder also hurts, and I get headaches all the time. And now I've got gut problems and I've got fatigue and I've got all these other things that go along with it, right? So
Mm-hmm.
if you don't manage that pain, or if you don't have the right answer, shall we say, to that pain, then it can amplify. But there's also specific things that will increase the likelihood that a painful episode will turn into a chronic pain or chronic widespread pain. And yeah, so again, the depth of this is a lot. But so people's brains are kind of set into one of a couple different patterns when it comes to chronic pain. Pattern number one, you might say, is the sort of ignore. The person has some sort of a bias towards ignoring the pain, and therefore the brain actually starts to diminish its maps towards that area. So you'll see cortical maps, where, again, if you were just to imagine that somebody was sticking a needle in the brain and you would say, okay, well, where do you feel that? Where do you feel that? Where do you feel that? A good cortical map would say you've got a large area to cover a small amount of the body, which is to say I can feel a lot of detail around that area. So we would have a larger map for our hand than we would have for our entire back, right?
Mm-hmm.
When you have chronic pain, that map can shrink, and that shrinking is part of that particular individual's process of not noticing the pain anymore, right? And so this is one strategy for, if I'm not going to get rid of the pain, I can become numb to the pain to a certain extent. And this is the people who have had, and maybe you've seen them in your practice, they come in and they've got horrible problems and they're like, yeah, I didn't feel anything till last week. And you see an x-ray of their spine and they're absolutely obliterated. They're completely, turned into a big melted candle. Their spine is just destroyed. They're like, yeah, I was fine till last week. No, you weren't. These are the people whose brains have been wired such that ignoring that is the bias, if you will.
And
There's
I
another whole
imagine that that pattern is seen very often with elite level athletes that have gotten very good at just ignoring pain and continuing on with their training and their sport.
absolutely elite athletes or industrial athletes. You see the concrete worker, you see the person who's, in construction, or they just sort of beat their body for a living. And these are the people that are generally, insensitive to things like, their hands look like their feet, right? Like they're just one big callus from one end to the other. That's the general gist, right? And of course that can
Mhm.
come in different shapes and sizes, but that's the sort of the bias, is that, you just don't deal with that. And they would likely have an early life, uh, shall we say, setup that sort of favors that bit. Maybe they were always, in a safe kind of an environment where it was just never, considered to be, a big deal where things were. And there's going to be genetic factors with these things as well. And then the other version is going to be the opposite upbringing usually. Maybe there's been early life traumas. They were never really in a safe space growing up. These are going to be far more likely, either there was financial traumas or there was physical traumas or there was just always a threat, right? There's always something to look out for, always something to watch for, kind of an idea. And these ones have a far more likelihood of developing fibromyalgia, chronic fatigue syndrome, chronic widespread pain, because their brains amplify the pain so that they can have a greater radar dish, if you will, for threats. So they're constantly on the lookout for, what is the threat in my environment? What should I not do? What should I do to avoid this? Their brain is in a threat avoidance pattern. So this threat avoidance pattern says, I am smart enough. These are generally bright people. I'm smart enough to figure out that if I don't do this, then I don't hurt. So I'm not going to
Mhm.
do that because I don't want to hurt. The other group, they're like, I'm going to do it anyways. I don't care. The brain has a massive top-down pain regulatory module in the brainstem. Comes through a lot of the cortex comes through, but it comes down through some major aspects in the brainstem. And I know you didn't want me to get into the big names, so we'll stay away from the thick words. But in these areas, there are massive, what we call top-down pain control mechanisms. So imagine that in the brainstem, still inside your skull, it's not in the spinal cord, it's still in the brain, but it's, tucked up inside the skull. We've got an area, and its job is to send a signal down to your spinal cord at the various levels and say, I don't want to feel that. Okay, so it will
Mm.
either amplify or quiet the signals before they ever get to the level of consciousness. So those two people won't experience the same level of pain to the same level of injury, if you will. So somebody who has had a chronic pain situation, they won't necessarily even deal with it because it's a 2 to them or it's a 1 to them, even though their body is in a state of what we call nociception, negative signaling going up towards the brain. It's being squashed before it hits the level of consciousness. They're not that aware of that pain, right? Contrast that with the fibromyalgia patient, their pain is being amplified. So there are receptors on the cells in your brain stems for signaling for pain. These are generally glutamate receptors. And there are opioid receptors. So opioids are for blocking pain, cannabinoids for blocking pain, and these receptors should turn off the sensitivity, right? So we have amplifiers and we have shushers. So if we take and we have this person who has chronic widespread pain, they will generally amplify the action of the amplifiers. So those glutamate receptors will become more sensitive. They'll have more of them. Instead of having 3, they'll have 30. They'll have way more receptors for being able to detect pain. At the same time, their opioid and cannabinoid receptors become what we call internalized, meaning that they go inside the cell. So if the cell is like this, and on the outside surface, there's a little thing that is supposed to detect opioids when they're natural painkillers in your blood, that opioid receptor has now been turned to the inside. And it's not on the surface anymore. So the opioid comes along and it can't see the opioid because the receptor is been internalized to this inside of the cell.
Wow, so those receptors just basically go into hiding so that
Yes,
the opioids, which would normally block pain, they've got nothing to bind to, and then they can't do their job.
you got it.
Wow. Okay. So how do you fix that?
Wow, there's a question. Right. So it isn't a simple mindset thing. So just to be very, very clear for anybody that's listening, that's living with chronic pain, I'm not saying, well, just change your mindset, you'll be fine. That doesn't work. Okay. We have a very specific approach that we teach in my courses. We have a very specific approach that we use in my office. But let's explore some of that and we'll see what we have time to kind of cover. I mean, my pain course is 100 hours, so we don't have time to cover it, but we will do our best. So first things first is to eliminate any local pain. So I teach a couple of courses on how to identify and eliminate sort of hidden sources of local pain. So in many people, let's again speak about our fibromyalgia patients or our chronic widespread pain patients, they'll go to their doctor and they'll say, my shoulder's really hurting, or I hurt down into my arm, right? And then the doctor will say, well, that's your fibromyalgia. And they get the same, you know, gabapentin, pregabalin, whatever kind of drug that they were going to get anyways, and it really doesn't solve the problem. Or they go to the chiropractor, they go to a physiotherapist who does the same thing that they wouldn't necessarily do with every other patient, or also says, you've got fibromyalgia, and there's only so much I can do. As a rule, most doctors cringe when they see a patient with fibromyalgia because they don't understand how to handle them. So there is a way to be successful with that. And I'm hoping that becomes more popular. But anyways, what my approach is to assess that area using a very specialized sort of set of assessments to look at everything that I can look at with that shoulder, like look at it one way, backwards, forwards. And I use a lot of motor testing with that to determine where there might be a, it's not exactly preclinical, but like very subtle aspects that are associated with that. So for example, I might have somebody come in, and I had them yesterday and I had them the day before, where they have, say, a blood flow that's restricted up here in a area that we call the thoracic outlet, but it isn't bad enough that most doctors would recognize it as thoracic outlet syndrome, and yet it's intermittently there. It's there when they're sleeping, and it goes away when they're up, and unless they have their hands over their heads for too long, it doesn't really bother them. But if you hit the right set of circumstances, it does. Okay, I'm going to eliminate that. And I'm going to eliminate that by moving that rib off of the collarbone and making more room for the subclavian arteries and making that space wider. I don't need to do surgery. I just need to open that space. Okay, now we've got more blood flow in there. At the same time, the same person, because they have an amplified system, they feel every little thing that's going on. So, okay, in the back of the arm, there's a mild restriction associated with the radial nerve. So they've got, if the you're going to be familiar with like a tinel tap test. So when you're doing testing for nerves, you can tap on the nerve, and if it creates more tingling, oh, you've got carpal tunnel, kind of a thing. Well, one of the little tricks that I teach is to use a motor test. Like, so for a radial nerve, you're looking at finger extensions, right? I might tap over that radial nerve, and if it makes that muscle weak when it was otherwise strong, it's too sensitive. And we might decompress that nerve, and oh, now it's strong. And even if I tap, it's still strong. So this gives us a tool to be able to look for subtle things that are being amplified in the body. It gives us a window into seeing where are the problems that are affecting this person, causing things, and that have some potential for amplification. And then for my chronic widespread patients, I just do it for the whole body. So we check the entire back, the entire neck, the entire skull, the jaw, the sinuses, the chest, the abdomen, both arms, both legs. And I do it in about 5 minutes because I have a very, very efficient system. And we release all of the restrictions, all of the fascia, all of the nerve entrapments, all of the joint mobility issues, all of that stuff. And with widespread pain patients, we do it from head to toe. Now, that's different than what we would do in, say, your case where you're talking about your low back and then your shoulder was bothering you, and then your shoulder went away, then your back was bothering you. So you were having a wonderful aspect of top-down, brain-based control of that low back pain, because something that is more closer to the brain, something more proximal to the brain, was the signal. And it was so loud that when your brain sent down the signal, the opioids, to say, it worked. It worked very well. Your opioids worked great. And they
Wow,
turned
something was working back then. Amazing.
it was working. You were having so many opiates that the low back pain couldn't get to the top because it was being
Mm,
blocked closer to the brain.
okay.
Right?
Okay, gotcha.
So in your particular case, everything that I would care about would be about restoring function and making sure there's no nerve compression, making sure the nerves are being regenerated. Everything I could do to get that brachial plexus injury to restore. And at the same time, since I don't charge by the body part, I would also be looking at this chronic low back pain that you have, because I would assess everything and I would look at that and I would say, okay, well, that's something else we should do. While you're in the office, let's deal with this other thing as well. And hopefully by the time one resolved, the both would be better and away you'd go.
Well, one of my
So
discs completely disintegrated and was basically gone.
yeah, and you know what? That's where there's some neat technologies that we can use. So when you used a PRP to do that, what you're basically saying is, I'm going to take my regenerative chemicals called growth factors, and I'm going to take them from my blood, and I'm going to spin them and concentrate them, and then I'm going to stick them into that area, right?
Mhm.
We use in our office, because I don't do all the needles and stuff that some other people do. We use in our office, we use a focused shockwave to do that sort of thing. So a regular shockwave is called a radial shockwave. It's basically a tool about yay big. It has a hammer on the end of it, and the metal plate strikes the other metal plate, and that creates a sound wave that travels through the tissue. Okay? That shock wave, as it travels through the tissue, it compresses the cells. And when the cells get squashed a little bit, they'll release their growth factors into the
Mm,
surrounding interstitial fluid. So
okay.
that, and then you hit it again, and it does more. And then because you have to space the treatments apart, if you're going to do this properly, you space the treatments apart, you let the growth factors build back up in the cells, and then you squash them and let them out. Then you let them build back up again, then you squash them and you let them out.
Mhm.
Okay?
Mhm.
We do that with the focused shockwave. And then it's essentially the same thing, where we're taking these growth factors in the tissues right there and allowing that the opportunity to make all of the osteophytes and the grasp and the other, and everything to kind of work back. And if you, whether you do it with a stem cell, whether you do it with a PRP, whether you do it with a focused shockwave, you're basically coming after the same essential mechanisms. We usually add laser to the focused shockwave to increase the productivity of the cells, because it's going to increase cellular activity and multiply the effects of whatever you're getting, right? So we use focused shockwave because of two main things, and then a really important third thing. So the two main things is that it has a smaller, like a shorter shock wave that's higher. So it has greater amplitude with a short. So the wave on a normal shock wave might be something like this. The wave on a focused shock wave is shorter and higher. So it has more ability to compress. It's a sound wave, right? So every time you hit it, so that sound wave is smaller, it has greater ability to compress. Okay. that greater ability to compress is also focus. So if you would think about the thing that emits the shockwave is a parabola. It's like a satellite dish, right? And because of that, it focuses it to a point that is a certain depth away from that. And it's always a fixed point away from the speaker. So the focus shockwave is a literal sound wave emitted by a speaker. Okay, this is a really cool speaker, right? It's not metal that we're smacking against another metal plate. So that focus is always at a depth, which means that we can get really, really deep with it. So a radial shockwave has its greatest impact at the skin, and then it dissipates as it comes out away from the skin. So the deeper you want to get, if you want to get to a hip, you've got to go through a lot of tissue. It can only penetrate the standard thing that we know right now is it probably will only penetrate about 1 to 3 centimeters on a radial shockwave. That's being generous. And that's if you turn it way up. So if you've ever had shockwave, you know that it's excruciatingly painful. If it's not painful, you're not doing it right. It has to be painful in order for it to give enough energy to go past the skin and get to the stuff underneath of it. So people do it all the time for plantar fasciitis and elbow tendonitis and things of that nature, which are chronic pain syndromes, but they're local. And so we're treating them locally. But they are shockwave's very effective for it, but it's excruciating. And I'll have somebody come in, they had their right foot done with the plantar fasciitis with the shockwave, and they really don't want to have the other one done because it was so painful. And then ours is not painful. So the focus shockwave doesn't hurt. And it doesn't hurt because the energy is happening inside the tissue. If the skin level is set here and the focus level is there, you've set an exact depth. And so what these things have is they have a little sponge, a little jelly pack on the outside, and different depths of jelly pack make it so that the depth that you are penetrating the skin is 1 centimeter or 4 centimeters or 7 centimeters. And depending on the depth of the tissue you want to get to, you can get really deep into a hip or really superficial into a supraspinatus tendon or something, or the sole of your foot. And so you can set the depth with the little jelly sponge so that but it's always the same distance from the speaker, but it's always going to be past the skin, which means the skin doesn't get hurt. And so it doesn't hurt like a regular shockwave. The downside is that it's $40,000 for the machine instead of $4,000. So the doctor has to buy this $40,000 monstrosity. But I've bought them. I love them. They work better than the other stuff. And it makes me happy because people get better. We've done thousands and thousands and thousands of these, and we have an 85-95% success rate with them. People have knees that are destroyed. I mean, I got guys with knees that they're 75 years old. They golf every day, but they can't golf now because their knees are destroyed, and they look like a horse. You know what a horse's knee looks like? It looks like that. And you're like, what have you done to these? There's no cartilage left. They're absolutely bone on bone. It's just horrible to look at.
I've got lots of patience with those kinds of knees.
Yeah. So we do that. We do the focus shockwave on him, and he's out golfing and he's doing everything he wants to do. And he's happy to pay for the treatments because they work so very well, and he can live his life, and he doesn't want the surgeries, and this is how he wants to live. So he'd rather pay for the focus shockwave sessions and be able to go out and do what he wants. Is he going to get all the cartilage back in his knees? No, but it doesn't need all of it. He needs just enough to create a layer where there's no pain, right? So we get all of these all the time, and we do really well with those. So if we were treating you with that shoulder, I would be looking for any of my little impingements, finding anything that I could find there, making sure there's nothing that's grabbing and pushing onto anything that shouldn't be pushing on. And I'm not just saying, okay, we're going to go and crack stuff. We're going to be very, very diligent looking at all of that stuff. And then we're going to probably use that. If we know that disc is gone, we're going to use that focus shockwave, and we're going to get that nice and deep and get that disc and get that thing starting to come back. And not only that, when you hit it with the shockwave, it was originally designed to get rid of kidney stones. So you get rid of some of these little bone spurs, not a ton. Like, you're not going to say, I did 5 treatments and it's gone off the x-ray. but you're going to get some of the calcium to resorb, and you're going to get some of the sharp edges off, and you're going to get some of that stuff to kind of clear out. And it's going to start to do better. I got ladies that are 82 years old, and you adjust them and you do this and you do that. Nothing helps at all. And you do this machine and it works really, really well. So that's, and again, this is one of about 100 tools that I have. So it's it's not the be all and end all for everybody, but in your case, what you're talking about with your disc being gone in your neck, that plus laser would be at the top of my list. I would also combine that with supplements for regrowing cartilage, because I found a nice little paper that, well, it wasn't a paper, it was a review of papers. It was a meta-analysis. And so it showed all the different studies that were using, in this particular case, it was pulsed electromagnetic field therapy for regenerating cartilage. So they looked at pulse, because that's another tool we have in our office.
Mm-hmm.
So I looked at this paper for pulsed electromagnetic field, and it's okay. These guys got unbelievable results. They're like 200% better and everything. And everybody's like, yeah, it's good. It's 20% better. And I'm like, okay, well, what are these guys doing that these guys aren't doing? Why are the results so dramatically different? Usually they're not, unless they're cheating on their research, it's usually not that dramatic. He's saying, is this person biased on his results or whatever? So I looked at his paper, and what they were doing that was different is they injected them with an intravenous, well, not injected, but they had a bag that they would do with their pulsed electromagnetic field sessions. And in the bag was, because they were an osteopathic doctor, they had prescription rates and stuff like that. So they had ibuprofen, they had like a glucosamine sulfate in there, they had some vitamin D in there, and they had some other, I can't even remember there's other drugs that were in this concoction, but they were for anti-inflammatory kind of aspects and so on and so forth. Can't
No
remember that.
shark cartilage.
No shark. But there was always a sulfur donor for sure, right? So that you're like that chondroitin sulfate kind of an idea, and some anti-inflammatory aspects, and I think some blood thinning aspects or something like that, as I recall. In any case, because I haven't looked at the paper for a while, I just know what I use in my office to kind of mimic it. So I said, okay, well, I was using my machines for a while, for probably a year before I found this paper. Since we've added the supplements, our results have gone up from about 85% to about 95%. We're really pretty on the mark successful with these things. And it is no small part due to the fact that I read this paper and it had to do, and we add in where the patient takes a joint supplement, a broad-based joint supplement with chondroitin, glucosamine, MSM, yada, yada, yada. And we give them curcumin with boswellia in it as the sort of the herbal anti-inflammatory kind of mix. And we give them a vitamin D and a vitamin K. And that was my research on what was the natural thing that was the closest to the cocktail that this guy was using, right?
Yeah.
And when we add that in, it's pretty rare that we fail these days. So that's been really helpful, because then what you're doing, again, you're compressing cells, you're releasing growth factors with the shockwave. You're asking the body to make more connective tissue. Well, if you have the raw ingredients to do that, and you're controlling the inflammatory response, you're actually getting better results, right? All of those vitamin D, vitamin K, all of that stuff is going to have its effect, and you're asking the body to heal. You're sort of saying, just do, well, it's going to do better when you add these things in. So that's been the sort of secret sauce to getting that result to be even better than we got it before.
And then it sounds like, going back to our initial conversation on the difference between localized, isolated pain versus widespread pain, when you do have the patient that comes in that says, I hurt everywhere, then what changes?
Yeah, so that's a completely different approach. Now, we will always identify local pain factors first, right? Like, okay, yes, you hurt everywhere. What's the worst? And target in on those and make sure there aren't any treatments and make sure there aren't anything that's local. But then we're going to add a level to try to get them from having that big giant radar dish that is sensory overload and convert. So the brain balances out between motor and sensory. Okay. So if you add more sensory, the motor comes down. Okay. So pain, chronic pain, decreases motoricity. It decreases the excitability of the motor cortex, in fancy words, right? So, and
So
you
the more
measure that.
pain you have, the less you want to be moving around.
Correct.
Mm,
Absolutely.
yeah.
Right. And that's just because the brain's being depressed in an area that would otherwise move you. Right. So,
Mhm.
we use that. What we do in research to look at this is you use a transcranial magnetic stimulation, and you see how excitable the cortex is when you hit it with the magnet. How much does it take before the thing moves? This is how you determine the excitability of the cortex. And we know that when people are in chronic pain and there's a lot of sensory noise, that cortex is not very excited. It's not easy to move. It's not easy to do, right? It's not easy to think. It's not easy to create action. On the other hand, when you move, you decrease sensory. Okay. So we were generally taught in school when you did your anatomy that the motor side of things goes down to the alpha motor neuron in the cord, and that's what allows you to move, right? And then the sensory, that's the information coming up. There's also branches from the motor cortex that go down and block the sensory signals from ever coming up the cord. So there's a very distinct connection in the spinal cord through the interneurons in the spinal cord that block a certain amount of pain when you move. So we know that the research for the last 15 years has been that the number one treatment, if you will, for fibromyalgia is exercise. For widespread pain, exercise. What's the number one thing that fibromyalgia patients don't want to do?
Exercise.
Exercise. Why? Because it hurts. Not only does it hurt, but they suffer for days afterwards, right? But when they can do movement and they can do it regularly and they can do it at the right amount, they get less pain. All the research says this. This is just standard operating procedure. But because they're smart, they know that if they exercise, they're going to hurt for 2 or 3 days afterwards. So they're not going to do it because they're going to avoid that because they're smart people. And they are. They're not wrong. That's exactly what happens. So what we do is we try to find ways to bypass some of the mechanisms that would create more long-standing pain from exercise by increasing the output of the motor cortex and decreasing the sensory cortex, in addition to just the exercise. So some of the tools that we use, one is whole body vibration, because whole body vibration sends a different type of signal up the sensory system that is more, shall we call it, proprioceptive. It's more body aware than it is pain signal. It's a generally pleasant enough sensation. This whole body wooga 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 wooga. It doesn't hurt. My mom is 80 something and has had fibromyalgia for 40 years, 50 years. She can stand on a whole body vibration plate and she doesn't suffer as a result of doing so. So it's generally tolerable quite nicely. And that allows for us to add some movement into the system without having to overly exert the individual to start with. So it's a nice way to start that. Then if we layer music on top of that, music increases motor output. So what happens when you listen to something that's got a pretty good beat?
Yeah, you want to move to it.
Want to move, right? That is using a different pathway to increase motor cortex output. So you're getting that sensory. So there's something called music generated inhibition. So when you have music, you will reduce pain, right? So This is a thing where they put music in the operating rooms. They put, listen to music while you're getting your dental work done, this kind of thing, because music can reduce pain to a certain
Mm.
amount, right? I mean, it's not morphine, but I mean, it
Right,
does
right.
reduce pain to a certain amount, right? So, but it always, and part of the reason is because it helps with that motor cortex going up, that the desire to move, and then that reduces the sensory cortex. So we put them on whole body vibration, tell them to bring their own music, listen to the music while they are on the whole body vibration plate.
Mm-hmm.
Now we've got this desire to move while they're on that. And then we try to get them to dance on the whole body vibration plate. So they're just kind of doing, this right on the whole body. That movement, it's very safe. When it's enjoyable, there's far less likelihood to be a consequence afterwards. Okay. So my fibromyalgia patients, I'm like, she's like, what should I do for exercise? Dance in your living room. I love dancing. Great. Do that. Right? That's going to be wonderful for you because you're going to increase that. You're not, going to go beyond what your capacity is for doing that. And it's nice and safe. It's not like you cleaned out your garage. This is not the same thing, right? Those things are unpleasant. The brain doesn't like them and it fights against them. There's a whole aspect with that. Or, who likes, exercising, right? I mean, the after effect is wonderful for the people that get that, but these people don't get that, right? They don't get
Mm-hmm.
that buzz afterwards. They just
Mm-hmm.
hurt for days afterwards. So
Yeah.
dance, music, whole body vibration, those are wonderful ways. I just teach whole classes on vibration therapies and stuff like that we can use. And that allows them to get into a safer environment associated with movement. Now we combine that in our office with whole body treatment. This is what I was saying before. Whole spine, whole chest, whole abdomen, both arms, both legs, all get a myofascial joint, any kind of anything released that I can find everywhere in about 4 minutes, 5 minutes, something like that, if I know the patient well enough. And it allows me to change the sensory signalings throughout. It takes and it makes the whole system go on a global scale. And that's what you need. A simple spinal adjustment does almost nothing. And a full body manipulative does almost nothing. And maybe you will make them worse for most fibromyalgia patients. But dry needling works, right? What do you want to do? You want to do it as wide as you can do it. You want I don't know, I know nothing about acupuncture, but I know that when it comes to the research on dry needling, you want to do as much as you can with what you think the patient can handle, because you want the entire body to reset. You want the entire body to have a different view of itself
Mm-hmm.
rather than be stuck in this. What's going on there? Oh, look, you see that you see that thing? That's what, I wonder what that is. I wonder if I'm getting arthritis in that knee, or I wonder if that's a tumor, right? Like there's this threat that is constantly going on in the brain, whether it's conscious or not, in a lot of these patients, because they are extremely threat aware, right?
Right. Well, I really feel like the needling is such a great way of remapping those cortical maps of the body,
Yes.
for sure. And then there's a really fascinating uh, fMRI study where they were looking at I know we're trying to get away from all the technical terms, but the rostral ventral medial medulla,
Yep.
this part of the brain that's so important in the
For
top-down
pain.
inhibition
That's
of
the one.
pain. And
I didn't
you
say it, you did. That's not my, that's on
I
you.
know. But what I think was really cool was that this study was looking at the amplitude of low frequency fluctuations, the kind of neuronal activity in this part of the brain that's so
Yep.
important for shushing pain.
Yep.
And they did acupuncture at distal points. They did not do anything on the head or the neck. It was all hands and feet. 20 sessions, and it completely changed this one very specific part of the brain in the brainstem. And I just thought that it was such a cool study because it was on people that had migraines. And so the fact that there was no points done locally on the head and it still had that effect on these
That's
key,
exactly my point.
key brainstem structures changed their behavior with distal acupuncture.
You got it. And since I don't do that, I adjust the feet and I adjust the hands and I adjust the
Mm,
wrists and I adjust the
mm,
shoulders
mm.
and I make sure all that stuff's going on, right? So different approaches to accomplishing the same thing, which is to say, reprogram that brainstem.
Yeah, yeah.
Absolutely.
So then when you layer a brain injury on top of all of this that we've
Oh
already
my
talked
heavens.
about, that brain injury by itself interferes in some cases with this top-down inhibition of pain.
Of course.
So now when you have a patient coming in with either widespread pain or localized pain. I mean, again, so often I get the patient that was in the car accident, right? They've got an injury to their knee. They've got injuries to their back. They've got injuries to their neck. They've got seatbelt injuries across their torso. They've got the concussion. And so now they do have widespread pain and a brain injury. And now we have to deal with this.
So you want me to show you how to fix that in a couple minutes, right?
No, no, no. I maybe just does your approach change?
Absolutely. So we're going to do the same thing from a body standpoint if we're dealing with widespread pain. Okay. But we're going to layer in a brain recovery. So my Efforts Essentials course is that motor dual tasking course. So we're looking at do a motor activity, ask the brain to do a second task at the same time, see if that activity that you had them doing in the first place falters.
Mm,
And
mm,
so, do we have a problem with the ability of the brain to do this task and this task at the same time, this task and this task at the same time, this task and this task at the same time? And if it can't do that, then you say, okay, well, that's not a very efficient brain, and we should probably make that better. And the rule of thumb, and you probably know this from all of the work that you've done, is you generally work from the back of the brain forward. So we've tried to identify the most posterior, inferior aspects that we possibly can and make sure that those are stable first and then work forward. So brainstem, cerebellum, and then work our way forward into the various lobes until we get to frontal and prefrontal aspects and so on and so forth. So pretty hard to target, you know, very specific things. You say, okay, I'm going to target the, anterior cingulate cortex. Well, that's not something that has a wide receptor field to go into, but there are things you can do that will affect it. But you can't say, I'm only affecting that one area. It doesn't really work that way. But you can affect the left temporal lobe with high degree of specificity because of, sound, smell aspects associated with what side of the cerebellum you're going to activate. So, we would do that. We would just say, okay, based on our dual tasking, it looks like you have problems here and here. Let's work this set of receptor based activations into that part of the brain, see if it makes it better. Ooh, it does. You can now do that dual task thing. Okay, so now that becomes your exercise. That becomes your therapy, and we're now going to repeat and repeat and repeat until that area becomes stable. Now that area is stable. Now we can work on the next part of the brain and the next part of the brain until we run out of brain. When we hit the prefrontal cortex, we run out of brain, and we say, okay, we've got everything as good as it possibly can be. The brain is as good as it can be. Let's continue to do this because we're still having these other issues, but the brain has recovered. And we use tools in our office to measure all of this stuff. I have eye mapping tools, I have balance tools, I have all of the, hand mapping tools. I have everything that I could possibly do. My staff spends 2 hours doing an exam with all of my tools so that it's objectified. And then I spend 45 minutes with the patient and refine all of that stuff down to make a pathway for that particular individual patient. And then if they have to do therapies, then they get a prescription for the different therapies and they go to my therapist and I take care of them and put them into whatever routines that I have developed for them. And then they come to me and I get their whole body put back together and away we go. So that is how I can kind of efficientize my time. Because otherwise I'd be spending an hour with one patient. And where I live, that's hard to get anybody to sort of, cover, if you will.
hmm
Insurance doesn't really
hmm
do that around here.
Sure. Yeah. Well, that is a great answer. I love it. What would be your ideal research study if you could design one?
Oh my goodness. I mean, I actually I'm actually very excited right this exact second about a lot of the research that's being done on what are called microclots. So what they're finding is that people with long COVID and people with um, chronic fatigue syndrome and people with POTS have high propensity to these microclots. And so instead of your platelet aggregation being like that, the platelet aggregation is more like that. And it's not big enough to block the artery. You don't get strokes from them, but it gums up the whole works. And so we have these blockages that are temporary and they carry through and but the stuff's not dying, but it becomes ischemic a little bit or hypoxic a bit. And then when you move and you do stuff, then it blasts these things loose and then they start circulating around again. And there's this massive free radical storm that comes as a result of this, mixing of oh, we found this. Oh, and we blow up all of this free radical activity, so on and so forth. And so I'm working with like an enzyme kind of based treatment for that. And I want to see more research being done in terms of how can we, keep these clots from becoming a big deal in these particular cases. So that's where I'm getting excited about some things
Okay.
today.
Awesome.
Tomorrow
Yeah.
it'll be different, right? But today that's the
Well,
very
I can't wait to hear more about that when you start talking more about it in your courses.
you know what? I always share everything. I got I'm also really really looking at microbiome stuff and how can we make bigger, more specific pushes at changing the microbiome. That's kind of a big deal for a lot of things. So these are all on my radar.
Yeah. Yeah. Love it. Awesome. Well, where can people find you in Canada?
Well, I'm in Red Deer, Alberta, so that's maybe a bit farther away than maybe a lot of your listeners are. My
What
website is
is the population there?
the population for Red Deer is 100,000.
Okay. Half of
Yeah,
which have been your patients?
yeah. I've s- I've seen probably 40,000 people over the last 32 years that I've been in practice.
Amazing.
I mean, we have a trade area of probably 250,000, 300,000 at this point. But I get people that come to me from out of province. I get people that have come to me from the States. I get people that are come from across Canada that come to me because they heard something and they want to go to the person that had helped their friend or whatever it happens to be, right? And
Yeah.
so they'll drive a ways to get that work done. But yeah, my website is hoffmanwellness.com. You can email me. It's Dr. Norm, DRNORM at hoffmanwellness.com. And that's probably the best way to contact me.
Excellent. I will add all that in the show notes. Well, thank you so much for your time. You're a wealth of information and an absolute expert when it comes to the neuroscience of pain and doing the world such a great favor by sharing all your information with clinicians so that they have better tools to help these patients with complex pain disorders. So thank you so much.
My pleasure. Thanks for having me.
Yeah. Have a great rest of your day.
Yeah, you too. Bye.